Hey everyone, and welcome. Today we're cracking open the blueprint for primary bone tumors, the latest CAT protocol. Think of this as your guide to making your reports not just accurate, but incredibly clear and clinically powerful.
So if you're a pathology training, you know the feeling, right? That fresh bone biopsy hits your desk, and bam, a million questions pop into your head. This protocol isn't some boring checklist. It's your honest-to-goodness roadmap that's going to take you from that initial specimen all the way to a confident diagnosis.
And why does this matter so much? Because at the end of the day, standardized reporting is the foundation of great patient care. It means every single patient, no matter where they are, gets the benefit of a consistent, thorough workup. It's really all about getting it right every time.
All right, so what's new in this version? There are a few key updates you absolutely need to have on your radar. First off, lymphatic/vascular invasion, or LVI, that's now a required element. You also have to specify the tumor's laterality. Is it right or left? And we're going to talk about this more in a bit, but there are some big changes to how we report the mitotic rate. Staying on top of this stuff is just part of the game.
Okay, first things first, let's talk about setting the clinical stage. And I mean this literally. Your diagnosis starts way before you even lay hands on a microscope. This initial info is the foundation for everything that comes after.
Look, the protocol itself basically screams this at you. Bone pathology is a team sport. Your very first move should be to get in touch with your clinical colleagues, especially the radiologists. In these cases, trust me, the image is just as important as the slide.
So that brings up a really important question. Who are the key players you need on your sarcoma team?
And yep, here they are, your dream team. I can't stress this enough. Your diagnostic power, your confidence, it all goes through the roof when you're working hand in hand with a sharp musculoskeletal radiologist and the orthopedic surgeon who did the procedure.
Okay, this next point is absolutely critical because it's a decision you can't undo. The decalcification agent you choose matters a lot. Going with something gentle like EDTA is so important because it preserves the nucleic acids. That keeps the door wide open for all the molecular studies we might need later. But if you use harsh acids, well, you might as well just be destroying that precious genetic material, potentially slamming the door shut on those tests for good.
Now for the fun part, the histologic diagnosis. Really, we're trying to answer three core questions. Where is this thing? What exactly is it? And how bad is it? So let's kick things off with the where.
So why do we obsess over this specific site? Well, it's because the AJCC 8th edition actually has different staging systems depending on where the tumor is. A tumor in the arm is staged differently than one in the pelvis or the spine. That means getting the location right in your report is absolutely non-negotiable for proper staging. All right, next up, the small round blue cell tumors. This is one of the toughest neighborhoods in all of bone pathology. Why? Because under the microscope, on a simple H&E stain, these things can all look spookily alike. This is where morphology alone just doesn't cut it.
And that is where molecular pathology comes in and saves the day. This table is a perfect illustration of how we link what we see to the underlying genetics. See an EWSR1 gene fusion? You're thinking Ewing sarcoma. See a CIC rearrangement. That's a totally different type of sarcoma. This is what modern, integrated diagnosis is all about.
Okay, so we have an idea of what the tumor is. Now we need to figure out its personality. How aggressive is it? So let's dive into two key metrics that give us prognostic power: histologic grade and mitotic rate.
Now this is something that trips a lot of people up, so let's just clear the air. When we're looking at the slides, we use a three-tiered grade, G1, G2, and G3. But for the official AJCC staging, that all gets condensed into a two-tiered system. It's simple. G1 is low grade, and both G2 and G3 get lumped together as high grade.
And speaking of key metrics, here's another pretty big update. The 5th edition of the WHO, the Blue Book, has rolled out a new, standardized way for us to count mitoses. It's all about making our counts more objective and reproducible.
So the old way of kind of vaguely counting mitosis in 10 high-power fields? That's on its way out. The new gold standard is to count every mitotic figure you see within one precise, defined area, 1 square millimeter. This is a huge step forward for consistency between different pathologists and different microscopes.
And don't worry, you don't need a PhD in physics to figure this out for your own scope. It's actually super easy. Just follow these steps. Figure out your field diameter,
calculate the area of one field, then divide 1 square millimeter by that area. Boom, that's exactly how many fields you need to count. Simple as that.
You know, it's not just about the H&E anymore. Modern bone tumor diagnosis absolutely depends on special studies. We need them to lock down a diagnosis, to find prognostic clues, and, increasingly, to identify targets for therapy.
And these are the heavy hitters in our diagnostic arsenal. We've got immunohistochemistry to stain for specific proteins, cytogenetics to look for big chromosomal changes, and of course, next-gen sequencing to get a deep dive into the tumor's genetic code. These are the tools that solve the real head-scratchers.
And one of the most exciting areas where these tools are making a huge difference is in identifying what we call TK fusion tumors. Finding a fusion involving a gene like NTRK or ALK is a massive deal because it can literally open the door for a patient to get a life-changing targeted therapy. This is where pathology directly impacts treatment in a huge way.
All right, so how do we pull all of this together into a final report that makes sense and is actually useful? The goal here is to stop seeing the protocol as a bunch of boxes to tick and start seeing it as a guide to creating a clear, consistent, and clinically valuable document.
And if you take away one thing from all this, let it be this. Your pathology report is so much more than just a diagnosis. It is a critical, actionable piece of communication that has a direct impact on how a patient is treated. When you use this protocol diligently, you're not just writing a report, you're creating a powerful tool for patient care.
So I'll leave you with this question to chew on. As we get better and better at finding these targetable alterations, these TK fusions, how do you think that's going to reshape this protocol in the future? It's a pretty exciting time to be in this field, that's for sure.